Thank you for inviting me to speak. This is a case-based discussion, so feel free to jump in, ask questions, etc. I may ask you questions. All right, so the outline of today's talk. So it's basically to talk about the approach to evaluation of transplant recipients with suspected infection, to talk a little bit about some of the concepts that we use when we're evaluating these patients, engaging their risk of infection and what kinds of infections they might be at risk for. And then we'll jump into some cases and talk about commonly seen infections and other causes of fever following transplant. So some of you may have come across this concept, the net state of immune suppression. It's basically a conceptual concept. It's basically a conceptual measure of the global state of immune suppression in a transplant host. And the idea behind this concept was introduced so that we can take a holistic view of our patient and take into account all of the risk factors that are contributing to their immune suppression and their risk of infection. And at any one time, the net state of immune suppression for a transplant host is the result of the interplay between host factors and the environment. So thinking of it in that way, we basically think of risk factors as those which are intrinsic and then those which are extrinsic. So intrinsic risk factors, oftentimes we don't necessarily think of these things, but the underlying disease state itself sometimes contributes to immune deficits. So before you give anybody iatrogenic immune suppression, chemotherapy, etc., because of their disease itself, they have certain immune defects. CLL patients, for example, have hypogammaglobulinemia. Your AL amyloidosis patient has hyposplenism. Your patient with MDS, etc., like T-cell malignancies. MDS patients are going to have innate immune deficiencies, dysfunctional neutrophils. T-cell malignancy patients certainly have cell-mediated immune deficits, and it's well known that they're actually very much similar to your AIDS patients. So these are things that come along with the disease itself. And then, of course, as patients get sicker, other comorbidities, there are metabolic conditions, as we all know, that also add to your immune suppression and your risk of infection. Thinking more so along lines of extrinsic factors and more specific to the transplant host. So the solid organ transplant host, it's a big surgery, of course. There's a lot of anatomic disruption. There are many things that can go wrong at that level. You can have graft injury, fluid collections, wound complications, bile leaks, etc., urine leaks in your kidney transplant recipient. In your lung transplant recipients, you can have tracheal anastomosis disruption, etc. So there are things that are a direct result of the transplant surgery itself. And then, of course, are the drugs that we give patients, so the type of immune suppression. And at any time, usually we're not using, and especially initially, no one is on one immune suppressive agent. They're usually on a regimen of 2 to 3 immune suppressive agents. So it's always a combination of the various types of agents that really determines the degree of immune suppression. What really makes a big difference is induction therapy. So your kidney transplant patients are more likely to get induction therapy. Anyone who's getting a lymphocyte depleting agent like ATG, etc., is going to be more at risk of infections than someone who did not get that. And then, of course, there are certain infections which you develop because you're immune suppressed, but they add to your immune suppression, so it becomes a vicious cycle. So if you have HHV6, there's pretty much 100% guarantee that there's CMV going on somewhere, and the two of them are working together to make you even more immune suppressed. And all of these different viruses have been found to have immune modulatory properties and have been shown to have a role in causing conditions like post-transplant lymphoproliferative disorder, HCV recurrence in somebody who had HCV, so post-transplant recurrence, vanishing bile duct syndrome, which is basically chronic allograft dysfunction in liver transplant recipients, bronchiolitis obliterans syndrome, and then coronary atherosclerosis in your cardiac transplant recipients. The other thing that we use in our approach when we're evaluating transplant patients is the timeline of infection that I'm sure all of you are very familiar with. So at any point, it is important to recognize that this is not a fixed timeline. It's a dynamic timeline. It certainly goes back and forth. And at any one time, your risk of infection depends upon your net state of immune suppression. But typically, everything being equal, what we see in the first month of transplant is mostly nosocomial infections, hospital-acquired infections. Immune suppression at this point in time is, of course, high, like especially for someone who's had induction. It's incredibly high, but you're not going to see opportunistic pathogens at this point in time. Most of what you're going to see is going to be nosocomial. They're in the hospital. They have surgical site infections, leaks, line infections, C. diff, all that. Other than that, one thing that we do pay attention to in this time period are recipient-derived infections. So that's why we do active surveillance for colonizers, and we try to cover for these very operatively and early on so that they don't, to reduce their chances of getting infections from whatever they're colonized with. The one unusual thing that you can see in this early time period is donor-derived infections, and we'll talk about that a little bit more. So nosocomial, recipient, and donor-derived early on. Moving on to the second part of the timeline, this is where your immune suppression is reaching its highest point, and hopefully up to 6 months, you're coming to a point of stable immune suppression. At this point in time, your risk of infection, most people have left the hospital, so certainly, there's that element. They have gone back into the community, they have contact with the community. Your risk of infection is largely determined by what prophylactic agents you're on. And in this day and age, we have universal PCP and antiviral prophylaxis for everyone. So some of these infections that we used to see in this time period, like CMV, EBV, herpes, etc., we don't really see so much anymore. And we, in fact, now see them later on after transplant in the more than 6-month window. If you're seeing someone like coming more than 6 months out from transplant with fever or any question of infection, really the first question should be like, how is the transplant doing? That's really the biggest determinant of what this patient's going to come in with. If the transplant is healthy, if he's doing well on stable immune suppression, most of what you see in this time period is travel-associated illnesses, community-acquired pathogens. I mean, you certainly may see greater severity of disease because they're immune suppressed, but most of it's going to be influenza, community-acquired pneumonia, etc., because now they're out and about with their lives. The one thing you do see here, as I mentioned, is the late viral infections, because at this point in time, most people are off of their prophylaxis. At 6 months or so, especially if they're on baseline immune suppression, they're off of their valganciclovir, their CMV prophylaxis. So this is where you would see some of these viral infections start popping up. All right.
Why did you talk the viral prophylaxis at this point at 6 months?
So we'll talk about that a little bit, but basically, I mean, that's kind of the prophylactic, strategy that everybody follows. Like the guidelines are to give up to 6 months of prophylaxis for someone who's high risk. It can actually be 3 months in someone who's lower risk. So when we did not have these agents, transplant in the 70s, 80s, no one was doing PCP or antiviral prophylaxis, you would see CMV at 1 month. You would see it a lot earlier. But now we see it later on. All right, so just to summarize the approach, we're looking at, to gauge what the patient is at risk for, we're looking at how long it's been, what prophylactic agents are you on, what is your immune suppressive regimen, is it stable or are you undergoing rejection therapy? We of course look at pre-transplant serologies and environmental exposures. Other things to remember is that you can often see multiple infections in these patients. Clinical presentation can certainly be subtle, and it can be harder to diagnose infections than in someone with a normal immune system. And then we must always keep at the back of our mind non-infectious causes of fever, such as allograft rejection, graft versus host disease, etc. All right, so case number 1, we have a 46-year-old patient. He has Hep C cirrhosis. He undergoes deceased donor liver transplant. He receives routine prophylaxis, which at our center is ampicillin sulbactam. So very early on, post-op day 3, he's hypotensive. There's a drop in the hematocrit. He goes back to the OR. No surprise, they find a hematoma. He gets an evacuation washout. And now post-op day 4, he's hypotensive. He's having fevers. He's requiring pressors, etc. He's getting sicker. And so you send off blood cultures. You have surgical cultures, which show you some growth. So as you can see, one's an Enterococcus faecium, it's an ampicillin resistant and vancomycin resistant isolate. You have an E. coli, fairly resistant organism, cefoxitin sensitive. ceftriaxone resistant, cefepime MIC is at 8, so still susceptible, but the MIC is high. So this is a classic example of what we see. And, you know, in the United States, of course, drug resistance is really high, like, so very common for us to see drug-resistant pathogens. So this is a classic nosocomial infection in the early post-SOT period. So as I mentioned, you don't see opportunistic pathogens in this time period. You mostly see healthcare-associated infections, and we do pay attention to colonizers and past infections, of course. So as people are being assessed for transplant, are being evaluated, we actually do active surveillance for MDR colonization. So our patients get rectal swabs, and I'm sure you've seen that in the hospital. We basically want to know if they're colonized with something that's carbapenem resistant or not. MDR infections have been shown in the literature to be associated with increased morbidity and mortality. So we certainly try to target our peri-op coverage based on past infection and colonizers to hopefully reduce the risk of this early post-transplant. Okay, 45-year-old patient, ischemic cardiomyopathy, undergoes heart transplant. So again, like we're in that first 30-day window. 2 weeks later, you find this in the patient's blood. What do you think this might be? Anybody want to take a guess? Sorry? I'll give you a hint, like the donor might be from Central America. Yeah, exactly. Yeah, so this is Trypanosoma cruzi, and this was a patient here like some years ago. So this is donor-derived T. cruzi infection. Like, so this is, you know, one of those unusual like things that you have to watch out for. So early on after transplant, if we find someone like who's having fevers, like it's not explained by any of the recipient workup, then we do talk to UNOS and we take a look at the donor information and all of the donor cultures to see if it could be something donor-derived. So this was donor-derived T. cruzi infection, and as you know, someone who is seropositive can be chronically infected. Up to 30% of those who encounter this pathogen go on to develop end-organ disease or chronic infection due to Chagas. Okay, so donor-derived infections, like very briefly, every pathogens in every category have been transmitted from donor to recipient, like everything from viruses to bacteria, fungi, mycobacteria, parasites have been transmitted. So basically, we try to mitigate the risk of donor transmission through a very careful assessment of the donor at the time that transplant harvesting of the organs is being considered. This is often challenging because most donors are young, healthy, and they die either in a motor vehicle accident or, you know, it's an unexpected death. In a lot of cases, they've never seen a doctor, family's not around to give you a history. Like, so a lot of times this is challenging, making a determination as to whether this is an appropriate donor or not. If we feel the donor is high risk, we now employ NAT testing to make sure that we're not catching somebody who's in the window period for, say, HIV, Hep C, Hep B, before we accept the organs. And then there's a set of labs like that gets done on the donor that is very similar to what I'm sure you've seen we do on the recipient. So it's a similar set of viral serologies, etc. And then there's additional screening that we do based on risk for that, of that particular individual. Okay, so specific to Chagas disease, like which is an emerging problem in the United States, the estimation is that about 300,000 people are living with Chagas disease in the United States, and you know, there are certainly areas of higher prevalence because it is mostly immigrants who have the infection, like so Texas, etc., areas where there are a lot of more immigrants, like from south of us, from Central and South America. The seroprevalence is even higher. And as I mentioned, like someone who's seropositive, you can basically consider them chronically infected for the purposes of transplant. So the AST, the American Society of Transplant, has come up with guidelines on how to assess for the risk of Chagas disease. Like, so essentially we follow a targeted screening approach where, like, you know, donor and recipient both, like if they are from a high risk area, then we go ahead and screen them. If the commercial serology comes back positive, and if you ever come across that for any reason, the confirmatory serology, especially if something like transplant or treatment perhaps is being considered, like has to go to the CDC. So they do the confirmatory serology, and then they're able to assist us with PCR testing to see if someone's parasitemic or not. And we just recently did this for one of our patients. I mean, the treatment is benzonidazole is what's most commonly used, and it's only available through the CDC in the United States. So that's the route we have to go if we find this. All right, so case 3 and 4. So you have a 69-year-old male, LT recipient. He's post-op day 28 on your standard immune suppression. He did have a complicated course, had multiple bile leaks, etc. And now he has fever with yeast in the blood. And you have another patient that same day, like 56-year-old male, also a liver recipient, but 5 months ago, so a little bit further down. He's on stable immune suppression, had an uncomplicated course. He's gone home, and he's also coming with fever and yeast in the blood and some shortness of breath. So what do you guys think? What's the yeast in both of these cases? Is it the same? Is it different? I think the first case is really easy, right? Like there's more of a question about the second case. I mean, this guy is still in the hospital, like he's had like a complicated surgery, etc. Like, so he has Candida albicans, like no surprise. The other guy, like, I mean, stable immune suppression, like, but you know, he went out, uncomplicated course, lives upstate, some shortness of breath, so maybe something like crypto, right? So this guy had crypto. So just talking a little bit about these infections, like so invasive fungal infection following solid organ transplant, invasive candidiasis is the most common invasive fungal infection you will see. And we do have prospective data on this, like it's called the Transplant data from 15 US centers. They prospectively identified infections in these patients, invasive candidiasis followed by aspergillosis and then cryptococcosis. Like those are the 3 most common infections you'll see in solid organ recipients. Looking at it by type of organ, so no surprise, most of the folks who are at highest risk of developing candidiasis are your abdominal organ recipients, so kidneys, liver, small bowel. Across the board, though, across all organs, invasive candidiasis is the most common. The only exception is lung transplant, where you see invasive aspergillosis more commonly than you see invasive candidiasis. Another thing to remember, which can help you, gauge what the infection might be, is that, as I said, like invasive candidiasis is something that's going to happen early. Cryptococcus is typically actually a very late occurring infection. So in this study, when they looked at median time to onset of cryptococcosis, it was 575 days. So typically it's something that occurs really, really late after transplant. So not something that happens early. As far as invasive candidiasis is concerned, the risk factors are really like, there's a lot of overlap, of course, with what you see in the general population. Specific to solid organ transplant, things that we think about are acute renal failure, early surgical re-exploration, retransplant, colonization, of course, and then the type of anastomosis that I'll talk about in a second. So whether your patient gets an end-to-side anastomosis or gets a bile duct-to-bile duct anastomosis really determines your risk of post-liver transplant cholangitis and invasive candidiasis. So someone who gets enteric drainage is going to be at higher risk, of course, of these infections than someone who gets an end-to-end anastomosis. And over time, like this is just to show like that while invasive candidiasis remains the most common infection you're going to see as far as funguses are concerned, we are doing a whole lot better like over the years, like going from the 1990s to 2000. And the reason simply is that we've gotten better at doing transplants. And so a lot of these surgical risk factors, like operative time, blood loss, etc., like all of those factors have gotten better over the same period of time. So in this current era, like where transplantation has modernized, we've gotten better at doing surgery, etc., like the more relevant risk factors are your MEL score. So someone who has a high MEL score, that's been shown to be a risk factor for invasive candidiasis, fungal colonization, and then really a lot of stuff that you would think about in your general patient, broad spectrum antibiotics, lines, etc. The greater challenges actually now are some of these, it's certainly the shift in spectrum to more resistant species. We've gone from albicans to more non-albicans, and then of course novel species such as Candida auris, which I'm sure you've come across in the hospital. In the United States, most isolates have been echinocandin susceptible, but certainly in various other parts of the world, they've seen completely pan drug-resistant isolates of Candida auris, and it's already been transmitted through a donor. As you can see, this was a case report from Boston. So what do we do at Mount Sinai? So in light of all of these risk factors, our standard prophylaxis for a liver transplant is just unison. It's ampicillin sulbactam. If we identify that this is a high-risk candidate where fungal infection, invasive candidiasis is more likely, like chronic renal failure, fulminant failure, retransplant, then we would give fluconazole. And then, of course, at any time you have MDR colonizers or past infections, we modify our prophylaxis based on that. All right, coming on to Cryptococcus, so the third most common IFI. Just a few things to remember. No surprise, your transplant host has extrapulmonary disease. In 33% of the cases, they have fungemia. And as I mentioned, it's typically a late occurring infection, but it can occur early, like in our patient who was a liver transplant, and then it can also occur early in lung transplant. So those are two populations to keep in mind for early cryptococcosis. And I think this is well known, as they started looking at Cryptococcus outside of HIV and AIDS, the one population that was found to be at very high risk are the liver cirrhotics, who seem to have a unique risk for cryptococcal infection and very high morbidity, mortality due to it. So certainly think about it, send your cryptococcal antigen. It comes back a lot faster than speciation. We don't have a PNA fish or any quick way of identifying yeast in the blood, so you're left finding out whether somebody did a germ tube or not, etc. So if you think someone is at risk, I think it's good to check the serum cryptococcal antigen to get a quicker answer. All right, so we have another case. It's a 68-year-old gentleman. He has FSGS, end-stage renal disease. He undergoes renal transplant, and we're now seeing him 11 months post-renal transplant. He was in Texas. He was visiting with his daughter, and he had some sick contact. I think one of the children was sick. So shortly after that, he has nausea, vomiting, belly pain. He has some fatigue, myalgias that have now gone on for 4 weeks. He goes to the local ER there. They tell him, listen, you have a stomach bug. We didn't really find anything else. Your platelets are low. However, I'm not sure what your platelets usually are. You should just follow up with your transplant clinic. So he's been on stable immune suppression. I list his meds there. So he's on Bactrim still, metoprolol, and on Lantus. Those are his only meds. So he comes in, exam is benign except for some abdominal tenderness. And as you look at his labs, you see that he's anemic. He certainly has thrombocytopenia. His creatinine is a little above baseline. His LFTs are not too bad. What would you be thinking about in this patient? Sorry? Parvovirus? It's a very good thought. It could be parvovirus. Because he's anemic, he had a sick grandchild at home, right? I guess the key is really here, so he's 11 months post-transplant, and if you look at his medicines, what is he not on? Yeah, exactly. He's not on the valganciclovir. Absolutely, yeah. So he's finished his prophylaxis. At this point in time, even someone who's high risk would have finished their prophylaxis. So this is what I was talking about, the late onset CMV disease that we now see in the more than 6-month window at a point when people are off of their prophylaxis. So he came back viremic at 4,539 international units. So this was certainly CMV syndrome, with the fever, the thrombocytopenia, myalgias, etc. But with this epigastric pain, etc., maybe gastritis, upper GI disease because of CMV. So this is an older paper from the 1970s. This is when, for the first time in the renal transplant unit at Brigham and Women, they started seeing CMV syndrome and they didn't know what it was. So they described it as the 40-day fever. So what they saw was that hit day 40 after transplant, everybody has drenching sweats, fevers, thrombocytopenia, abnormal LFTs, and they weren't sure if this is one of the retroviruses, what this is, but turns out it's CMV. So this is the older timeline. So as you can see, the CMV onset is so much earlier before we did prophylaxis than now. Now we see it certainly later on after transplant in this age bracket. I'm sorry, timeline. So classic risk factors for CMV, so certainly induction therapy, if that's a big risk factor. Anybody who's getting lymphocyte depleting therapy, critical illness, comorbidities, specific to transplant, the cold ischemia time has been shown to be associated, longer cold ischemia time, and then the use of mTOR inhibitors. And then the other risk factors that we more commonly think about, like outside of these, it's basically the donor and recipient serostatus for CMV. So your highest risk recipient is going to be someone whose donor was positive and he himself is negative. That's the highest risk. So that's kind of like getting a bolus of CMV at the time of transplant. And on top of that, we give you immune suppressive agents. You already have no existing immunity. So that's the patient who's going to be at highest risk compared to someone who's D minus, R minus. That's the patient who's going to be at lowest risk of developing CMV after transplant. It certainly varies by transplant type. So lungs and intestines are highest risk and kidneys are lowest risk. Basically, organs where there's a lot of lymphoid tissue are the ones that are going to be at high risk. And then, as I mentioned, there are certain viruses which kind of work in synergy with each other. So if you ever find someone who has HHV6 viremia, definitely check a CMV. CMV is probably happening somewhere. Well, so it's basically just has to do with harvesting of the organ. So there's warm and cold ischemia time. Yeah. So it has to do with circulatory death. All right. So in terms of CMV infection, we think of it in terms of direct effects and indirect effects of CMV. The direct effects, we have asymptomatic viremia, and then CMV disease, which is CMV syndrome, and then tissue invasive disease. And here, as you know, in transplant recipients, most of what we see is GI disease. The most common thing you're going to see is colitis, which is different from what you see in AIDS patients, where encephalitis and retinitis are more common. Those are less commonly seen in your transplant host. Pneumonitis really is more in the stem cell recipient and then maybe in the lung recipient, but not otherwise. And then there are all these indirect effects, and I'd mentioned this a little bit earlier, that it is an immune modulatory virus. And that's why even if we find a few copies of CMV in someone's blood, we're not, on a stressful day, any of us can have CMV if we checked each other's blood, a few copies of it floating around, but we don't have to act on that. We don't do that in your AIDS patients, for example. We don't treat viremia without end organ disease. But we care about these indirect effects in the transplant recipient, and especially the association with acute and chronic allograft rejection, and that's why we start treatment, even if it is just viremia without any other problems. So our usual approach is universal prophylaxis, and then that's followed by preemptive therapy. This is a bit of a debate in the transplant world, and as time goes on, you may actually see things change. A lot of people say that we should not be doing prophylaxis and should be doing preemptive therapy from the get-go. So, and one of the things that makes sense is that the D plus R minus patient, if you put them on prophylaxis, you're reducing their chances of developing CMV immunity because you're suppressing the virus all the way. So maybe let them be a little viremic, just monitor them, treat them if they're viremic, but otherwise leave them alone, and maybe you would reduce their chances of late onset disease. So this is a randomized trial that's going on to see if one approach is better than the other. And these are the guidelines. I don't think we have to go through this. I will mention that Mount Sinai is a low-dose prophylaxis center. So our full dose of CMV prophylaxis is 450 and not 900. Guidelines all talk about 900. There's some data coming up on low-dose prophylaxis. So except for our D plus R minus patients who are highest risk, everybody's getting 450. The other population where we're doing full dose prophylaxis is the small bowel population. So the high risk patient would get six months, everybody else would get 3 months. And we don't do lungs here, but every lung transplant recipient or a combined heart lung would get up to 12 months of transplant. And that's supported by data that it helps to keep, basically there's mortality benefit with continued therapy. All right, I won't go too much into diagnosis. Like, I mean, we do PCRs here, of course, like that's kind of become the mainstay of things. We don't really do cultures. We do tissue immunostaining, of course, like for our GI biopsies, etc. This is, I just put this there out of interest. Like this was a semi-quantitative way of diagnosing CMV. You certainly couldn't do it in someone who was neutropenic. You had to have cells to do this. The PP65 is a matrix protein in the CMV. So they would just, on a slide, they would make a smear and they would stain for the PP65 and they would give you some sense of how many cells are infected, more than 10, less than 10 per high par field. That's how they used to diagnose. But obviously we've gotten a lot better at that. I won't mention too much about resistance, except that if you have somebody on adequate therapy and it's been around 3 weeks of what you feel is adequate therapy, and the viral load is either increasing or not changed, that's when you think about sending off a resistance panel and think about changing treatment from your first line. All right. We have another patient, intestinal transplant recipient, who's 8 months post-transplant, who's coming in with shortness of breath. Preceding this, like he's had a rough course, he's had rituximab, high-dose steroids, so he's pretty immune suppressed for someone who's 8 months out. And these are his meds. He's maintained on atovaquone, valacyclovir, in addition to his immune suppressants. And this is what he has on his CT scan. What do you guys think? Yeah, good. So there's a big pneumothorax there, right? So we all know that atovaquone is not first line. We very often see breakthrough cases of PCP through atovaquone. And really the key thing to remember here, like again, most centers would have stopped at 6 months to 12 months. Important to reinitiate prophylaxis if someone is on rejection therapy. This often gets forgotten, someone is 2 years out, but if they're undergoing rejection therapy, restart their CMV and their PCP prophylaxis. And Bactrim, of course, is ideal. And basically, we used to see this in the first year is traditionally the highest risk period for PCP, but we've gotten so good at preventing it with Bactrim and with other agents that now it's actually, again, something that's been pushed out. So second year post-transplant is where you see it the most. So there's a lot of research going into identifying risk factors for PCP in the era where we do a lot of prophylaxis. All right, so we have a heart transplant recipient. He's undergoing rejection therapy. He's on these meds, no recent travel. He spent some time in his garden. He lives in Long Island. He's coming in with fever, cough, shortness of breath. This is his chest CT. So as you can see, there's an effusion, there's consolidation, and he undergoes a thoracentesis, and this is what we find. Pleural fluid is exudative. It looks like it's infected. So you kind of see this beaded organism, branching, filamentous. Yeah, that's great. Yes, it is nocardia. So definitely typical for that. He's someone who spends time in his garden, works with soil, etc. So that's his risk factor for that. We do tell patients to wear masks, etc., to reduce their chances of these infections, especially when they're more immune suppressed than usual. And the key thing to remember about something like nocardia is that there are many, many species, and they all vary in terms of their drug sensitivities. So this is one situation where you may want to double cover, with 2 agents till because there really is no standard drug of choice. It really depends on what the species is. So in our patient's case, he was double covered, I forget with what, I think with ceftriaxone and imipenem, and eventually got sent out on Bactrim. But there are many, many species that are Bactrim resistant, and to the agents that we used to think of as drug of choice, it's not really the case anymore. Okay, this is an exciting case. This is an intestinal transplant recipient, has lived his entire life in Manhattan, very well-to-do, etc. Really no adventurous travel, nothing. In that sense, very boring ID patient. We couldn't really get any history from him. Listen, really, and he's 9 months post-transplant, and he's been doing well. So they actually reverse his ostomy. They're we don't really need to do biopsies anymore. We're going to reverse your ostomy. He's doing fine. And then 10 days after, he has fever. He develops GI symptoms. And then he has respiratory symptoms and very quickly has bilateral interstitial infiltrates and gets intubated. And of note, like several of his outpatient biopsies did not show rejection, but they showed non-specific inflammation. What do you think? Yeah, maybe with his GI tract, right? Like, but different bug, different parasite.
Giardia?
Sorry?
Giardia?
No. Strongyloides. Yeah. So that classic presentation of the GI symptoms, like he had like some form of enteritis that nobody could really find out what it was, you know, and then like he develops hyperinfection. Like, so they find strongyloides in his VAL, whatnot, like badness. He did well though, like from what I heard, he was treated and went home. But in this case, while we could not prove it, it was felt to be donor-derived because the patient himself truly had no risk factors whatsoever, had led a very protected, you know, existence, etc. So it was felt to be donor-derived. Strongyloides, as you know, like is something that establishes a cycle of autoinfection, right? Like, so it's something that can continue to auto-infect your body and it can reactivate in the setting of immune suppression. And this is Shirishu Prakar, like, working with the Live on New York ID group. Like, so they work with the main organ procurement agency in our region. And they basically were able to describe their experience, which was very different from the CDC, which is that working very closely and assessing donors, there's ID doctor that gets called for any high risk donor. They were able to prevent a lot of transmissions. All right. And I'll give you another example here, like just to jump guns a little bit, but this is an ATLL patient from Jamaica. So this is a stem cell transplant recipient, and she was diagnosed with CMV GI disease, with C. diff, and with strongyloides all at the same time. And this is like basically a really, like I feel very bad about this case because this is a missed opportunity for screening and for pre-transplant treatment. Like, so at this point when she's post-transplant, developing graft versus host disease, etc., like had we given her this treatment, maybe she wouldn't have, but nobody checked. Even though she's from Jamaica, she's from an endemic area, it should have been checked. So it's just something to keep in mind because treatment is very simple. If you find someone who's strongyloides seropositive, it's 2 daily doses of ivermectin, and then you repeat that in 2 weeks. So that's really it, like so treatment is very well tolerated, etc. There's another case, like living-related kidney transplant 19 years ago. The patient is from Sri Lanka, living in New York for 30 years. Again, you know, like for 30 years anyways, he's been very settled here, no problems. His kidney is now failing, and he's being considered for retransplantation. He gets admitted with fevers and sweats. And of note, like all his workup, like previously he's been found to have very low level EBV viremia, like which is felt to be reflective of his immune suppressed state, is not felt to be the cause of his fever. They reduce his immune suppression, etc., bring him in for FUO workup, and he has a very large liver mass. What do you think this might be? Could be, that's a good thought, yeah. Could be anything, right? I guess. Sorry? This could be anything. Like, I think this is maybe an unfair like question. Like, this was MTB. Like, so this patient, like he was transplanted so long ago, like his LTBI status pre-transplant, we of course like screen for LTBI. We don't know his status and we don't know if he ever got treated or not. You know, certainly like, I mean, data does support that treating LTBI pre-transplant has an impact on, you know, has a positive impact on post-transplant TB rates. So in this patient though, we didn't know like what his previous status was. He was from Sri Lanka, from an endemic area. This is probably a reactivation and not a new infection, but we can't really say for sure. So he was started on RIPE. Story continues, and here it's the paper. I think in the interest of time, we won't go into that, but the key thing is that treatment with INH for LTBI pre-transplant does impact MTB reactivation post-transplant. I won't go into this. So now 4 weeks into TB therapy, he's having recurrent fevers, he's having some eye pain, he gets admitted with new onset cytopenia, worsening renal function, fluid overload, he gets started on dialysis. And now he has this thing on his brain. Is it TB? Is it something else? Again, could be anything, right? This turned out to be PTLD. So this guy like starts out like with, he's a failing graft, right? They switch his immune suppression. Maybe he gets overly immune suppressed is our theory. Like, because we actually switched him to belatacept, which is felt to be less potent immune suppression, but maybe it was too much for him. We don't know. So he develops the TB, like reactivates his TB, and then he goes on to develop PTLD. It's all a result of like over immune suppression, basically. And I think the EBV viremia that we were seeing like was, telling us like that he's overly immune suppressed. His immune suppression was being reduced, but I think it was still too much. So anyways, he developed PTLD. He did well. He's getting chemotherapy. So risk factors like for this, like again, it's your EBV serostatus, like so just like CMV, D plus R minus is the highest risk status, and then of course like receiving like rejection therapy, etc. It's a lymphoma, like so the signs and symptoms are going to be your B symptoms, etc. Lymphadenopathy, like that's how these folks would present. PTLD is oftentimes like it's extranodal, etc. Usually disseminated. There is no role for antiviral agents. This is a common question to us when somebody gets diagnosed with PTLD, that listen, this is EBV associated, should we start acyclovir or not? The answer is no, like, the horse is out of the barn. The treatment is chemotherapy, and there really is no role for any antivirals at this time. This is a nice example of some of what we've talked about in terms of net state of immune suppression and folks being more immune suppressed than meets the eye. She was on a medicine team. I'm not sure if any of you remember her, but she was this really petite 61-year-old like Korean female. There was certainly a language barrier that we all like dealt with. Very, very vague symptoms when she came in. So chordoma, complicated neurosurgery, and she ended up with panhypopituitarism. So she's maintained on chronic hydrocortisone that everybody feels is physiologic dosing for her. So coming in, like she's really not felt to be very immune suppressed, etc. A lot of like results on her were actually dismissed. That listen, this isn't making sense on this patient. No, like we're going to repeat it or check it again, etc. But she comes in with fevers, belly pain, some diarrhea, and then she very quickly goes on to develop respiratory failure. She requires a non-rebreather and eventually a BiPAP. And you can see she has these fluffy, like kind of clustered infiltrates on both sides, more on the right side. This patient, like, so her CT showed terminal ileitis, like, so, okay, there's, she has some GI symptoms, not sure what's going on there. She was found to be CMV viremic, like initially at 50,000 and then went on to be higher than that. And initially, like, nobody believed that this patient had CMV, like, till her symptoms kept getting worse, like, and her viral load kept going higher, because the thinking was that, again, like she's just on a little bit of steroid and she's not that immune suppressed, whereas clearly she is. All of this is showing us that she's more immune suppressed than we're recognizing. She then like went on to develop RSV upper respiratory tract infection, so her nasal swab came back positive. With this CT, like they then went on to do a BAL, and she actually had RSV lower respiratory tract infection as well. So this patient got really, really sick, like with whatever little like steroid that we felt she was on. So she was also found to have PCP, which really threw us because at that point in time, she was getting better. So we placed her on Bactrim, recognizing that she's definitely colonized, but maybe did not have pneumocystis. So again, like, it's something to think about, like in these patients, like, because we do, like we do therapeutic drug monitoring, like where we measure tacrolimus levels or cyclosporin levels, but they don't give you the whole picture. And that's why there's a lot of data coming out on immune parameters that we should be using, like, cell-mediated immune function assays on these patients, looking at CD4 counts, immunoglobulin levels. All of this, as time goes on, is going to become standard. We're going to start looking at immune parameters like we've done with our HIV/AIDS patients, because, like one size does not fit all when it comes to iatrogenic suppression. This is a cool case, like which I saw as a fellow. I always put it on there like as kind of a photo quiz. This is a shortcut syndrome patient. She's an intestinal transplant candidate. She takes nothing by mouth. She's completely dependent on TPN. And she comes in with these blistering lesions, like which are a longer hairline, perioral, like hands and feet. She's from the United States. Yeah, from the Midwest. No, not so much. It's a blistering lesion. Yeah. It's not infection. I think that's why I put that in there. This is something any of us could see, like really, like in someone who's malnourished, alcoholic. Yes, who said that? That's awesome. Yes. So this is like acquired acrodermatitis enteropathica. So something that we describe in babies, like, for a different reason. That's an autosomal recessive condition, bad diaper rash that doesn't go away. The baby's not absorbing zinc. You start putting zinc, give the baby zinc, rash goes away. The same thing has now been recognized in someone who's malnourished and alcoholic, etc. In this patient's case, someone forgot to put zinc in her TPN actually when they looked at her prescription. So as soon as they started giving back zinc, like the lesions like completely, very, very rapidly like went away. So this was a cool case because we made the diagnosis like as ID because we were kind of the superstars. The whole thing led to a grand rounds. Oh my God, how was the zinc missed, etc. Like so, it was cool. But yeah, like certainly good to think of other causes. I mean, she went through vancomycin, acyclovir, etc. like for no reason. It's the last case, like an LT recipient. Some of you may have seen him. He was admitted several times like before the diagnosis was made. High-risk sexual behavior. In the last 3 months preceding this presentation, he had received at least 3 different courses of PEP and had come in with some abnormal LFTs here or there, like which resolved. And now he presents with an FUO, cytopenia, transaminitis, gets really sick, multi-organ failure. And we find this eventually on a 3rd bone marrow biopsy. So that's hemophagocytosis, right? So you can see like the cell, the macrophage that's engulfing like the white cells and the red cells. And in this patient's case, it's interesting, we're actually in the process of writing it up. We felt that it was related to, what we found was that it was related to HHV8 infection, which again, we think of like someone like who's from like the Middle East, like Mediterranean, where it's endemic and a lot of people are seropositive, but it's actually really common among HIV and HIV who are MSM. There's a very, very high rate of it, seropositivity in the United States. This patient probably got primary infection because his history was of very high-risk sexual behavior prior to all of this. And his PCR was, I think, by the end of it, it was 79 million or something. It was really, really high. So this is hemophagocytic syndrome. These are just some, I can send you the slides, like this is just some stuff you can use, like to talk about strategies for safe living, infection prevention for solid organ recipients. I just put in here like guidelines for vaccination. Again, 3 to 6 months, we do start vaccinating, revaccinating our patients to protect them. So in summary, like the timeline and the spectrum is dynamic, and at any time it depends upon how immune suppressed you are and where you are, what your environment is. OIs are typically seen in the 1 to 6 month window, but you can see them earlier or later. Always think about excessive epidemiologic risk or excessive immune suppression if something is outside of the usual pattern. Like think of what might be going on. Like is there like a construction site by you? Like is there something going on at home? Like if someone's coming with aspergillus, etc. Those are things to think about. Lastly, don't forget your community onset pathogens. Think about vaccinations. Think about non-infectious etiologies. And remember, it's not uncommon to see co-infections. This was a recent publication like by Shirish Uprakar and some of our fellows, which basically was, it was a crazy case, like, but elevated beta-D-glucan and 3 different possible causes of the elevated beta-D-glucan, which were all found in the same patient. So we can all, take our pick, like, is it the Hickham's dictum or the Occam's razor? Thank you.